and good evening, everyone. All right. So today we are going to talk about the excitation-contraction coupling. Before that, last time we have talked about the action potential. We are going to continue from there only. We are always, as our ritual or as our tradition, we are going to start with a wonderful quote. See over here. However difficult life may seem, there is always something you can do and succeed at. So we are going to take the inspiration from this, and let's start with a wonderful quote. All right. So last time we have discussed about Dinkar. What was Dinkar? Depolarization happens because of influx of sodium, and potassium efflux causes repolarization, right? So if they are going to give you such graph, first of all, whenever the graphical question is going to come, please remember that you have to see the x and y axis. Don't get scared. The question's answer is going to be there in the graph itself, right? So see on the x-axis, what is there in the x-axis? Nothing much important, that is time, right? On the y-axis, we do have two y-axis over here, relative permeability of the ion and membrane potential. With the membrane potential, I will get to know. So this is the purple color graph, which is showing you the action potential. And look at the RMP. RMP is minus 70 MV, and we know as soon as I see that this is the minus 70 MV RMP, that means it must be the neuronal action potential, right? So what will happen over here? That as soon as you give the stimulus of plus 15 MV, it is going to go towards the firing level, that is nothing but minus 55. As soon as you reach to minus 55, which ion permeability is going to increase? That means which channels are going to open? Sodium channels. So of course, whichever you can see over here, if I extrapolate that, as soon as the action potential start going towards the spike potential, the sodium permeability also increases proportionally. And as soon as you reach to the spike, we do two things. What two things we are going to do? First thing is close whatever channel is open. So we are going to close the sodium, and which channels will be open then? The potassium channels are going to open. And please remember, potassium are Kachwa channel. K for potassium, K for Kachwa. That means tortoise. They are very slow to open, and they are very slow to close. Now, while they are closing, what will happen? More and more potassium is going to rush outside. And because of that, what will happen? Of course, there will be slow closure. See over here at this point, the RMP has been reached, right? At this time, the potassium channel must have closed completely, but that does not happen, right? They should have closed completely, but that shouldn't happen. That doesn't happen, and this closure will take time. And because of that, the potential of the neuron will go in more negativity than the RMP, that is known as hyperpolarization. So if the examiner asks you why there is a hyperpolarization seen in the neuronal action potential, your answer should be that it is because of the slow closure of potassium channel. So see over here, whichever is going to rise first and follows the action potential graph, that is going to be the sodium ion, and whichever rises later on and keep on continuing to have that permeability, that is going to be potassium, right? So they are not going to give you this. They are going to instead give x and y and ask you to identify. It is going to be sodium and potassium. Now, there is something known as refractility. First of all, let's see what is refractility. Refractility means no response, absolute no response. But over here, we are going to modify it as no second action potential or no second response, which is going to be seen. Now understand, from the beginning, or we can say that from the firing level, if I go towards the 1/3 of repolarization, what I mean by 1/3 of repolarization, let's say that this is the action potential of the neuron from minus 70 to minus 55. I'm going to have the, you can say, firing level. And from here, I'm going to go towards the spike potential. Now, when I'm returning back from the spike potential towards the RMP, that phase is known as, this is known as repolarization. If I make the three parts of repolarization, the first half will over here and the second half will get over by this time. All right. Now, whenever this first half of the repolarization or first 1/3 part of the repolarization is over, till that time from the firing level, this is known as absolute refractory period. Now, what is absolute refractory period? I told you refractility means absolutely no response, right? So from here to 1/3 of repolarization is complete, I'm going to call that as absolute refractory period, or it is also known as ARP. On the other hand, from the 1/3 of repolarization till the RMP, from R to R, I'm going to have relative refractory period. Relative refractory period, I'm going to call that as RRP. So if I have to show you in the diagram, that is going to be from here to here, right? RRP, unless and until my potential of the neuronal membrane comes back to normal. All right, so that is going to be, yes, absolutely right, Scavenger, and Shashidharan is also there. All right, so this is the RRP. Now see over here, what is the clinical significance of this thing? First of all, why this happens, that we'll see later on. First of all, let's see the significance. In the neuronal action potential, the ARP is very shorter, right? But in the heart muscle, when we are going to learn about the heart muscle's action potential, it has a plateau phase, and because of this, that the ARP is going to be very, very long. Recent INICET MCQ also, and because of this ARP, long ARP, what happens in the heart muscle? It benefits my heart muscle. How? The heart muscle, it cannot be tetanized. What is tetany? Tetany means sustained contraction. I cannot have the sustained contraction in the heart muscle. Otherwise, what will happen? If sustained contraction keep on going in the ventricle, the ventricles will go in the cardiac arrest. I don't want my heart to go in the cardiac arrest. Otherwise, no filling will occur, and next time there will be no ejection and no perfusion will occur to my organs, right? And that's why we don't want tetany. Thankfully, nature has given the protective phenomena, that is long ARP in the cardiac muscle. Now talking about RRP. In the RRP, if you give the stronger stimulus, what will happen? Yes, the second action potential will take place. The second response will take place, right? That doesn't happen in the ARP. No matter how strong stimulus you give in the ARP, there will be no second response. Absolutely no response, right? Usually I give the example of my brother. What happens is my dad tells him to study, right? With love, with anger, with getting upset, frustrated, right? With the language of shoes and chappals, right? And the bells, but he doesn't understand. He doesn't study. He's in the engineering, right? He's doing BTech. But as soon as the exam comes near, his girlfriend is going to say to him that if you do not pass, I'm going to leave you, right? So now he starts studying. So if you give the stronger stimulus than the first action potential or the first stimulus, and that too in the RRP, what will happen? Definitely the response will come. Now, what happens at the heart? Ectopic foci. Ectopic means the site should be abnormal. Ectopic literally means abnormal site. So from the abnormal site, if any, you can say cells, they are going to fire the action potential that acts as a stimulus on the cardiac muscle, and definitely that will create the second action potential even before the first response has been it has not completed, right? And that's why what will happen, there will be arrhythmias which can occur. And please remember that this condition is known as premature ventricular contraction. premature ventricular contraction, and that can lead to, if they ask the most risky period for arrhythmia. So see, RR is coming now. So risky period for arrhythmia, it is going to be RRP. It cannot be ARP, right? So most risky period for arrhythmias in the heart, it is going to be the RRP, right? Let's see why this happens. There are two gates of the sodium channel. So if I draw a sodium channel on a cell, so suppose this is the sodium channel, this is the outer gate and this is the inner gate, right? If I have to allow the sodium to come inside, what should I do? I should open both the gates. Then only the sodium can enter. But look over here. What happens? This inner gate, which is known as the H gate, it is also known as inactivation gate. This gate is very stubborn. Once it is closed, you cannot just open it up with a higher force, right? No matter what you do, it is going to be closed for some duration. Please remember that. And this is the activation gate. You can open this gate, but you cannot open the H gate. This activation gate is also known as M gate. Remember, there is a cycle which is going to follow the sequence. What is the cycle? That if, let's say, the gate is open first of all, or the channel is open, when we are going to say that the channel is in the open condition, whenever there are two gates, so let's write two gates, H gate and M gate. Both the channels are open. Then I'm going to say that yes, this is the open state, and this open state will be followed by the inactivation state. What is the inactivation? Of course, the H gate is going to be closed and this is going to be open. This is known as inactivation, you can say, state. And once it is going to get inactivated, after some time that will go and follow the closing state. Once it is closed, then only you can reopen it back. You cannot open the channel from the inactivation state. You have to close the channel first and then they will be opened up. So please remember, when we reach to the spike, what happens is, actually we say that sodium channel is closed, but sodium channel actually doesn't close completely. It is in the inactivation, you can say, state. But of course, if any of the gate is closed, of course, the sodium will not be able to enter inside. So that's why the sodium permeability is going to decrease, right? And close means which gate must be closed? You know now that this gate will open and this M gate will be closed, right? And please remember, it is much easier to open the M gate, right? And that's why what will happen, of course, if you are going to give the stronger stimulus, the M gate can be opened and hence you can go from the closed condition into the open condition. Let's revise it quickly what I mean over here. First thing first, let's say these are the two gates, right? One is the M gate, one is the H gate, right? What will happen? Both the gates are going to be open and hence the sodium can enter into my cell. Now, what will happen? There will be inactivation. Inactivation means the H gate is going to be closed, M gate is open. No matter how strong stimulus you give, the H gate will not open. It will remain closed for a particular time. Right now, slowly and steadily, what will happen, that it will come in the closed state. That means this gate is open, that is the H gate will be open, but M gate is closed. Now, this is not that stubborn gate. You give the stronger stimulus, this will be open and hence it can come in the open condition. But please remember, you cannot go from the inactivation condition towards the open condition. You have to close the channel first. And when this is going to occur, this is going to occur. That means from the inactivation to closed state, you are going to go once the 1/3 of repolarization is complete. So for the closure of the channel, we require the 1/3 of repolarization, and that's why till that time we are going to have what thing? We are going to have the ARP. Now what I mean by that, I'll just draw the diagram and I'll tell you. Suppose this was the action potential and suppose till here we had the ARP. Now no matter how strong stimulus I'm going to give in this phase, here, let's say only plus 15 stimulus, plus 15 MV stimulus was required. Now I have given plus 200 stimulus, right? Millivolt of stimulus. Then also no second response is going to take place. But even if I give the stronger stimulus, let's say instead of plus 15, even if I give plus 20 millivolt of stimulus over here, definitely the second action potential will fire up. So please remember, the action potential was going like this. Suddenly I gave the stimulus. So now without a particular relaxation, without complete relaxation, the second response has come, right? That is known as premature response. Without the complete relaxation, this can happen, right? From the closed state, you can go in the open state. That is the cause for it. Now they are going to ask the two question: what is the cause for refractility? If they ask what is the cause for refractility, then you are going to say that this inactivation state is responsible for refractility. But if they ask what is the significance, then you are going to write these two things. That is, the long ARP is there in the heart muscle, so heart muscle cannot be tetanized, and the RRP is responsible for premature ventricular contraction, that is PVC. Please remember, that is the significance. Now let's move on to the EC coupling. What is EC coupling? Excitation contraction coupling. Excitation contraction coupling. Excitation is electrical phenomena. You cannot see the excitation of the nerve or the muscle because it's an electrical phenomena, right? Electrical phenomena are depolarization and repolarization, which will be followed by the mechanical phenomena, that is the contraction and relaxation. So don't get confused between the electrical phenomena and mechanical phenomena. Electrical phenomena, we have to transfer it first of all from the nerve into the muscle, and as soon as you can you transfer the electrical phenomena in the muscle, now you have to convert that electrical phenomena into the contraction, which is the mechanical phenomena. This is whole thing is known as excitation contraction coupling. Excitation of the muscle will lead to contraction of the muscle. Let's see how that is going to occur. First of all, understand, we have to know the you can say structure of the nerve, muscle and their junction, right? So what is the structure and how it is going to look like? Suppose this is the nerve which is having this end part of the nerve, which is known as axon terminal. In the terminal, we are going to have lots and lots of vesicles, right? And let's say this is the skeletal muscle. If I talk about the junction between the nerve and the skeletal muscle, it will be called as NMJ. What is NMJ? Neuromuscular junction, right? At the neuromuscular junction, which neurotransmitter will be released? It is going to be acetylcholine. It is going to be acetylcholine, all right? Now what will happen? See over here. As soon as the action potential is followed, the action potential is going to come towards the axon terminal, and as soon as it hits the calcium channel, what is going to happen? The calcium channel is going to open up. Now please remember, in the nerve muscle physiology, in overall everywhere, the calcium is required for two things. First of all, if it is a muscle in which the calcium has been increased, that is going to lead to contraction. If it is not a muscle, it is going to cause exocytosis, be that the exocytosis of neurotransmitter or hormone or any other substances. Okay, so for the contraction and for the exocytosis, I require one and only channel or one and only ion, that is nothing but the calcium, calcium and calcium. All right, so the calcium channel is going to open, and just now we talked, it is not a muscle that we have entered till now. We are talking about the axon terminal, which is the part of nerve. So the calcium channel is going to open, and if it is not a muscle, what it is going to do in the nerve? Of course, exocytosis of which neurotransmitter? At NMJ we do have acetylcholine, so the acetylcholine will be released. So this is going to exit out in the form of vesicle, which is known as exocytosis. Now, as soon as this acetylcholine is exited out of the nerve, what is going to happen? It is going to go and sit onto its receptors. You can see over here, acetylcholine is released and it is going to go and sit onto the receptors, which are nothing but the acetylcholine receptors. Now, please remember that these receptors are going to act as a ligand-gated channels. I'll make you understand what it is. Ligand-gated. Actually, they are cationic channel. That means they are not specific cationic channels. They are not specific for any particular ion, but please remember the influx of sodium is much more as compared to other cations, and that's why we can call them as ligand gated sodium channels also. Why we have called them ligand gated, why not voltage gated? Please remember, in the nerve we have this channel, calcium channel. This is voltage gated. What does that mean? Voltage gated means it is going to sense the change in the voltage. That is, when the depolarization is going to hit that channel is going to sense the change in the voltage, and that is going to open up. But that is not in the case of acetylcholine channel. This channel, the acetylcholine receptor itself, they act as the channel, right? They are closed state. They are in the closed state in the resting condition. As soon as the acetylcholine, which is acting as a ligand, that is going to bind to the receptor, then these channels are going to open up. These two doors are going to separate apart, and that's how the sodium can enter into the cell. And the cell is nothing but the muscle cell. Now please remember, because of the entry of sodium, what will happen? Definitely there will be generation of action potential that is going to take place. Now the action potential has been taken place into the muscle. Please remember that. Now see over here, there is a mean calcium enters into the cell, then definitely the neurotransmitter has to say that I need to head out, right? So this is like a neurotransmitter. Whenever the calcium is going to enter the cell, the neurotransmitter has to do the exocytosis, exiting out, right? If I show you how it looks like, this is going to look like this. EC coupling in the nerve and muscle, it is going to look like this. Please remember, the skeletal muscle is not very smooth borderline, having the smooth borderline. Rather, they're going to have two different types of tubules. So first of all, let's understand what is the structure looks like. So see over here, there will be some changes which are going to occur in the muscle membrane where it is going to come in contact with the nerve. That is known as motor end plate. This specific area is known as motor end plate, right? Now, this hole is the muscle membrane. This hole is the muscle membrane. Now look over here, there are two tubules. First, this is the transverse tubule. This is the transverse tubule or T tubule. Why it is known as T? Because it is transversely present towards the, or as compared to, or transversely present in the sarcolemma. And who is present longitudinally to the sarcolemma? Longitudinal to the sarcolemma, we have L tubule. And what is this L tubule? This S tubule is nothing but the sarcoplasmic reticulum itself, right? It is longitudinal to the sarcolemma. That's why we are going to call it as L tubule, and this tubule is transverse to the sarcolemma. That's why we are going to call it as T tubule. So there are two tubules. Now, in the skeletal muscle, we till now talked that in a nerve, first of all, you have to stimulate the nerve. Nerve will cause the action potential generation. That action potential will come towards the axon terminal. That axon terminal will open up with channel, calcium channel, that causes the exocytosis of calcium. That calcium causes the exocytosis of acetylcholine, and that acetylcholine will sit onto its receptor, and the receptor itself, they act as the cationic channel or sodium channel, ligand gated sodium channel. The sodium is going to enter with a lot of force, and that if it is sufficient or the stimulus was threshold level, then it is going to generate the action potential. Once the action potential is generated, see over here, what is the property of action potential? क्या होती है property action potential की? That it is going to propagate forward. So it is going to go forward. कहाँ तक? It will go forward unless and until it hits the channel which is known as DHPR channel. What is DHPR channel? DHPR channel is nothing but dihydropyridine receptor. This dihydropyridine receptor is going to activate. Please remember, I'm saying that this action potential will activate the DHPR channel. Please remember, in the skeletal muscle, this GHPR will never open. It will just get activated. What is GHPR receptor? I'm writing it over here. Dihydropyridine receptor. Dihydropyridine receptor. Now, this is connected to another receptor that is attached to the L tubule. Where the DHPR is present? That is present on the T tubule. On L tubule, I'm going to have another calcium channel that is nothing but the RYR, that is ryanodine receptor. I'm writing it over here. I'm going to have ryanodine receptor. What this ryanodine receptor is going to do? Please remember that, see over here, the DHPR is attached to the ryanodine receptor with the help of spring-like structure. Whenever the DHP is activated, what will happen to the spring? The spring is going to coil. And whenever the spring is going to coil, this channel, that is RYR, is going to open up. So if I zoom it out or zoom it in, and I show you how it is going to look like. So see over here, DHPR and RYR in the resting condition. As soon as the DHPR is activated, what will happen? DHPR activated, the spring will coil, and that will open up the RYR channel. That will open up the RYR channel. Once the RYR is open, what will happen? The sarcoplasmic reticulum has lots and lots of calcium. Of course, that calcium is going to come into the myoplasm. As soon as the calcium is going to come into the myoplasm, what will happen? Calcium causes exocytosis in all other cells, but we are talking about muscle. So what happens in the muscle if the calcium has been increased? That is going to lead to increase in the contractility, or contraction will take place. Right? Again, whenever the muscles stop contracting, this channel will be closed. Why? Because I don't want any more calcium into my muscle. Right? So please remember that the RYR channel is going to open up over here. Right? If, let's say, I want to relax this muscle, now what I need to do? For the contraction, I took the calcium out from the sarcoplasmic reticulum into the myoplasm. I agree. But when I want to relax the muscle, I send this calcium back into the sarcoplasmic reticulum. How we can send that back? We're going to have one pump which is known as calcium ATPase in short, or we can call it as Sarca pump. What is Sarca pump? The CA is for calcium ATPase. Then what is SER? Sarcoendoplasmic reticulum calcium ATPase. Why it is calcium ATPase? Why we require the energy to send the calcium back? Because remember, the sarcoplasmic reticulum already has lots and lots of calcium. We are sending the calcium from the myoplasm into the sarcoplasmic reticulum. Again, that means from low concentration to high concentration, we are sending it. And that's why what is going to happen? Definitely the calcium concentration is going to go into the high concentrating area, and that's why we have to utilize the energy. Right? So this is how the contraction and relaxation is going to take place in the skeletal muscle. Let's see on the molecular level what is going to happen. Contraction means what? Contraction means active site of actin. See over here, these are the actin molecules which are going to form the filaments, right? Monomer of actin, they are globular in shape. When they are going to come together, they are going to form the filamentous structure of actin, right? So that is known as F-actin, filamentous actin, right? To which, see, there are going to be active site of actin where the myosin head is going to bind. And once the binding occurs, it is going to show the power stroke, which is going to cause the contraction, So see over here, this is the myosin head, which is attached with the active site of actin. But during resting condition, I don't want unnecessary contraction. So what I'm going to do is that to inhibit this unnecessary contraction, I'm going to take the help of Papa G of myosin, right? What is it? See over here in this diagram, very cute meme, right? Actin and myosin, they want to meet to each other, right? But who is inhibiting that? Papa J of myosin is not allowing them to meet. What they're going to do? They are going to cover the actin molecules and do not allow the myosin to bind to it, right? So Papa J of myosin, please remember that. Now, if I talk about the contraction, I need to displace the tropomyosin. How to displace this tropomyosin? Troponin is another type of molecule which is going to be there, which is heterotrimeric. What do you mean by heterotrimeric? It is going to have three different, you can say, segments. That is troponin T, troponin I, and troponin C. The calcium is going to go and bind to the troponin C. Why? Because troponin alone will not dare to go against Papa J of myosin. Why is it so? Because please remember, the Papaji has gun also. So the troponin is scared, and that's why whenever the calcium is going to come, the troponin will form the complex with the calcium, and that is how they are going to able to succeed to distract the Papaji, and hence the actin myosin can meet. Now see over here in the diagram, these are the actin molecule. The big ones are the actin molecule, and the dark purple color or dark blue color what we are seeing over here, these are nothing but the active site of actin, which is covered by this myosin, that is the tropomyosin. Now, as soon as the calcium is going to come and bind to this molecule over here, that is known as troponin. Troponin calcium complex will be formed, and this complex, this troponin calcium complex is responsible for contraction, right? This troponin calcium complex displaces the Papaji of myosin. See over here, the tropomyosin is got away from the active site of active. Now, this active site of actin, they are free to bind to the myosin, and hence the power stroke can occur, right? So please remember these four names: actin, myosin, tropomyosin, and troponin, right? The calcium and troponin, they are going to form the, you can say, complex, which is going to be able to distract or displace the Papaji of myosin. Okay, now coming to the applied aspect of it, what is the applied aspect? Please remember there are two diseases. First is Lambert-Eaton syndrome. What is Lambert-Eaton syndrome? Eaton. So please remember over here, the patient will feel better in the evening, and the patient of myasthenia gravis is going to be better in the morning. Let's remember, or let's get this concept here only, that if the concentration of, let's say, calcium is higher, the calcium is going to win. But if the concentration of antibodies are higher, they are going to win. So what happens during the morning time is that you have not stimulated your nerve properly. So what will happen? Still, the antibody concentration is much more. But when you give continuous stimulation to your muscle, what will happen? Slowly and steadily, of course, what will happen? The calcium concentration outside the calcium channel, they are going to increase, and eventually it will overpower the antibodies, right? So see over here, the meme is given that antibodies try to close the door, but calcium eventually finds the courage and open the door for himself, and definitely the patient will feel better, right? But on the other hand, if we talk about the myasthenia gravis, what happens in the myasthenia gravis is that patient is good in the morning, but as the day progresses, the acetylcholine levels in the morning are high, but as the day progresses, the acetylcholine is going to go down, right? And for the new synthesis, it takes a lot of time, right? Which the patient is not giving appropriately. So now what will happen? The antibodies are going to dominate the acetylcholine, and that's why the myasthenia gravis patients are going to suffer from the ptosis and the weakness, right? All these symptoms. So please remember, antibody against the Lambert-Eaton, that is going to, or antibody against the calcium, voltage gated calcium channel, that is going to lead to Lambert-Eaton. And if I say that the antibodies are against the acetylcholine receptor, or it is against the musk protein, this is the protein which is important also. So if the acetylcholine receptors are not in the option, mark it as musk protein. So when the musk protein is going to be inhibited, then also it can lead to myasthenia gravis. All right, now let's see what is the molecular basis of this. Now if I draw it on my own, how it is going to look like. Suppose there is a thick molecule, okay, which is symmetrical on both the sides. What is it? The complete thick molecule is known as, A band. And what is it? It is nothing but the myosin. But in the muscle, we don't just have the myosin, we have the actin also. You can see that the actin is what thing? The actin is thin filament, right? Now in this thin filament, if I discriminate that on the basis of, let's see how we can discriminate it. If I discriminate the whole of the myosin, this will be called as A band. Whole of the myosin is known as A band. Now, if I just talk about the actin, only actin, I'm not going to take the part of the actin which is overlapped by the myosin. So please remember, if I take only actin, now this only actin will be called as I band. One I band here, one I band here. Now, whenever I'm going to have the I bands, I'm going to draw exactly the middle line in between the I band. Please remember, I'm not writing this or I'm not drawing the midline into the actin. I'm drawing the midline of the I band, and these lines are known as Z lines. These lines are known as Z lines. From one Z line to next consecutive Z line, please remember, this will be called as sarcomere. Sarcomere. And that is the functional and structural unit of muscle. Muscle contraction occurs, that means sarcomere is going to shorten up. All right. Now, if you ask me, ma'am, if we are taking only actin there, can we take only myosin also in some scenarios? Yes, you can take the only myosin. So see over here, this is the part of the myosin which is not covered by the actin. Now, what this part is called as, if this part is only and only myosin, then it is known as H zone. H zone. When the complete overlap is going to occur of the actin onto the myosin, what will happen? This H zone can disappear. This H zone can disappear also. Now please remember, if I draw exactly the midline in between the sarcomere, then this is known as M line. This is known as M line. So please remember all these things. And what is the optimum length of the sarcomere? It is 2 to 2.2 micrometer. 2 to 2.2 micrometer is the optimum length for the sarcomere. What do you mean by optimum length? Optimum length means where the active tension is maximum. If tension is maximum, that means it is going to be in the partially contracted phase. All right, so please remember that. Now see over here, this is the same diagram, just that in that we have just drawn one unit. Over here they have given multiple, you can say multiple fibers of myosin and actin, all these things. So see over here, this is the pink one is the myosin and the green one is the actin. The pink one, the complete pink one is known as A band, and non-overlap part of the myosin is known as H zone. This is known as H zone. Now what is going to happen? See, there is the midline of the I band, that is known as Z line, and one Z line was there, one Z line was here. Now, if I start contracting the muscle, the overlap is going to increase. When the overlap start to increase, what will happen? Definitely, the point will come where the complete overlap of the actin will take place onto the myosin. What will happen then to the H zone? H zone can disappear also. This H zone can disappear. It will go away. There will be no H zone. That is possible. But please remember, the Z line, nothing will have to the Z line. Why? Because the Z line is made up of proteins, so nothing will happen to the Z line. What will happen to the I band? I band will be shortened up. Why? Because I band was only actin. But when the actin myosin cross bridges start to occur, the overlapping increases, and because of that, the I band will be shortened up. The I band will be shortened up. And because of that, the Z line are also going to come closer. The Z lines are also going to come closer whenever we are going to do the contraction. All right. Now, if I ask you what will happen to the M line, nothing will happen to the M line. Why? Because symmetrical contraction is going to occur both the side, and that's why M line will always stay there in the middle. And what will happen to the A band? A band will also not change. Why? Because it is complete myosin. Only the actin is going to slide, right? Myosin will not change its length. So who will never change? The Ma will never change. So please remember, no matter how big you are, no matter how elderly you are, no matter what is your age, who will never change? Ma will never change, right? If she wants to scold you, she will find some reason to scold you, right? So Ma will never change. Ma will never change. Please remember, this is the mnemonic. Everything is going to decrease, or everything is going to change its length, or it is going to come closer, or even the H zone, if we talk about, it is going to disappear. But Ma will never change. Ma will never change, right? So that is M line A band. It will not change. It will remain the same. It will remain the same. Now, please note down that this is the skeletal muscle that we talked about. That is the EC coupling of the skeletal muscle. There are few changes that I want you to note in your book. So what is the changes? First of all, let's write the skeletal muscle over here. And especially the cardiac muscle. Right? What is the calcium source? The calcium source of the skeletal muscle is going to be only and only sarcoplasmic reticulum calcium only. If I talk about CHF, then it is going to be, yes, the sarcoplasmic reticulum is most important, but before that, the ECF calcium is also important. Now, how it is possible that the ECF calcium is also taking part in my cardiac muscle contraction? This is possible because the DHPR is going to open in the cardiac muscle, which was not opening in the skeletal muscle contraction. So please remember that with the opening of DHPR channel. So who is having maximum contribution? Of course, maximum contribution is of the sarcoplasmic reticulum only. But this is placing, or this is having some minimal role, and this is very, very essential. Why? Because this will lead to calcium induce calcium release. The calcium will be released from the RYR only if the calcium has been entered into, or calcium is entered into the ECF, and that is inducing the opening of the RYR. So that is known as CICR. Write down CICR. You write this point in your exam. The examiner will be super happy. So CICR, that is nothing but the calcium induced calcium release that is seen in the cardiac muscle. It is also seen in the smooth muscle, but it will never ever be seen in the skeletal muscle. Please remember. Now this is about the contraction, right? What about relaxation? When I need to relax the muscle, let's see. I need to send the calcium back into the sarcoplasmic reticulum. How to send the calcium back into the sarcoplasmic reticulum? That is through the sarca pump. That is active pump. That is nothing but the sarcoendoplasmic reticulum calcium ATPase. Now there is a little problem. What is the problem? It was fine in the skeletal muscle, but I have two sources in the cardiac muscle. What are those? The sarcoplasmic reticulum and the ECF. So how to send the calcium back? It's very easy. Sarcoplasmic reticulum calcium will be sent back via the sarca pump. If you remember, in general physiology, we have discussed about sodium calcium exchanger. So that is going to help me out. NCX, that is sodium calcium exchanger. Sodium calcium exchanger is going to help me out. It is going to take the sodium and throw out the calcium out of this muscle whenever the cardiac muscle wants to relax, right? And that's how the excitation-contraction coupling, that means the electrical energy will be converted into contraction, which is the mechanical energy, be that the skeletal muscle or the cardiac muscle. CICR is going to be definitely present over here. Now understand that there are some structural changes also. First thing first, in the skeletal muscle and in the cardiac muscle. What are the changes in the you can say the sarcolemma and other channels? Please remember, there is going to be triad which is going to present in the skeletal muscle. That means there will be one T tubule and two L tubules. L tubules. What I mean by that? In the diagram, only one-sided tubule can be seen, but please remember there is going to be another T tubule, another L tubule which is going to be there. That means on one T tubule, for one T tubule, I'm going to have two L tubules, all right, in case of the skeletal muscle. In case of cardiac muscle, it is going to be dyad, one T and one L. One T tubule will be there. For every T tubule, we are going to have one L tubule. That is known as dyad, which is going to be present in the cardiac muscle. Two sources are there. Dyad is there. Everything is 2, 2, 2 in the cardiac muscle cells. Okay. So please remember that they are going to ask what is the triad, what is the dyad. You should be able to tell them that this is the dyad and this is the triad. All right, so that is all about the excitation contraction coupling. If you have any doubt, please do ask here, right? So we have covered very nicely all the excitation contraction coupling. We have seen even the molecular basis of contraction, right? And please remember, ATP attachment causes relaxation, and when the PI is going to get released from the, let's say this is the myosin head. When the new molecule of ATP, suppose this is the ATP, that is the adenosine triphosphate is going to attach to the myosin head, what will happen? There will be relaxation. That means the myosin head will change its angle to 45 degree. But when this ATP molecule will be converted into ADP and PI, then it will come to 90 degree angle. If the calcium is available, tropomyosin must be displaced, and now it can bind to the actin molecule. And when it is going to bind to the actin molecule, suddenly what happens is this ADP and PI which was converted, they will be released. As soon as they were going away. Meanwhile, the inorganic phosphate will give the energy to the myosin head, and hence myosin head is going to cock. That means it is going to change its angle at the neck. All right, so that is known as power stroke. Why? Because actin will be attached like this, and that is going to come inside from one side and from the another side, because always remember, this is going to be symmetrical and symmetrical only. So right, so what is going to happen? This side also the same scenario is going to occur. When the PI, ADP, that is adenosine diphosphate, and PI, they are going to get removed, what will happen? Definitely there will be power stroke, right? So two things you have to remember. What are the two things? The ATP attachment to myosin head will cause relaxation of the muscle, and when the ADP and PI, especially the inorganic phosphate, when it is going to get separated, ADP and PI, when they are going to get separated, that is going to, or they are released from the myosin head, then only the power stroke will occur. So please remember, these two things are different, and hence there is something known as a rigor mortis that you are going to learn in the forensic. What is the rigor mortis? Mortis means after the death. After the death, there is no one to generate the ATP and no one to provide the ATP. So if the ATP is finished, what will happen? ATP attachment is required for the relaxation. So relaxation of the muscle will not take place if there is no ATP. So if there is no ATP in the dead body, what will happen? Relaxation or contraction? Relaxation is unable to happen. So the muscle will remain in the contracted phase. That is known as rigor mortis, rigor mortis. So how the relaxation is going to take place? After some time, the proteins inside the muscle, that is actin, myosin, and everything else, it is going to be what will happen? It is going to be the one which is going to what we were talking, relaxation. So the attachment of ATP is going to cause relaxation, but when the ATPs are over, when the person dies, the relaxation will not occur. That is known as rigor mortis, rigor mortis. And when the relaxation is going to take place, actually relaxation won't happen. It is the denaturation of protein that is going to take place. Nitya is asking, can you tell us some application? If you want the app, it is going to be Cerebellum. I am teaching in the Cerebellum. Cerebellum pe all the concepts are available. Okay, so yes, it is. I'm there, Nitya, Dr. Nitya. I'm there in the Cerebellum. All right. So that is all about the EC coupling. If you have any doubt, please do ask me over here right now. So rigor mortis. Next time we are going to discuss the hypoxia or the types of hypoxia. What are the different 4 types of hypoxia and how the partial pressure of oxygen is going to change. The content of the oxygen is going to change at the arterial side, at the venous side. What is cyanosis? When the cyanosis will be present in which type of hypoxia? Which type of hypoxia will not have the saturation? So everything we are going to discuss in the next class. Okay, so that is all from my side for the excitation contraction coupling. Let's end the class with a wonderful quote that living is the art of getting used to what we did not expect, right? So that is what the art is. I hope you will become artist in upcoming future. So that is all from my side. I hope you don't have any doubts. So that is all. So see you next Wednesday. Next class will be on the Wednesday. All right. So at 6 p.m. most probably. Right. So that is all. Bye bye. Take care and be the artist.